don't go very far, because actually we are moving on now to our case study session. So we know the theory is all very useful. It gives us a grounding for practice, but actually it's when we start to look at examples of real scenarios, real patients, that we can start to really get into, well, what does this mean for our day-to-day practice? So our next section, Sam and Ollie have prepared a series of case studies that reflect different scenarios that they face in clinical practice and give an opportunity for you to think about how you would address that scenario. We will be going out with some polls so that you have an opportunity to have a think about what you would do in that scenario. They are anonymous answers, so nobody's going to call out your name and say that you got the answer wrong. No panic around that, don't worry. But we want to have a sense of how you would approach these scenarios, and Ollie and Sam will have a chat about their own approach to each scenario. So let me hand over to Sam Merriel and Ollie Hulson to take us through these case vignettes. Over to you.
Thanks, Amy. Hopefully you can see my screen.
Yeah, we can see it.
Perfect. And I can see it on the studio as well. So Sam and I have put together 4 short cases. These are entirely fabricated. So apologies if you have patients that fall into them, but it's just to kind of talk around some interesting points, really. So case 1. We have a 63-year-old gentleman who's come to see his GP to discuss his 6-monthly PSA test. He has an uncle who was diagnosed with prostate cancer in his 70s, but is currently having it observed. He gets up in the night to pass urine twice, and this has been the case for a long time, and he has no other relevant symptoms. He first had his PSA checked at 50, which was 0.7, and his last PSA 6 months ago was 1.4. And the question to the audience is, when should we check his PSA again? And if you look in the polls, you're given 5 options there. So the 5 options are 6 monthly, annually, every 2 to 3 years, at 5 years, or we should stop PSA testing in this gentleman altogether.
So we're already getting some answers in, which is brilliant to see. I'm very mindful that these are written by 2 doctors, and we don't just have doctors on the call. So if you're not medical, or you're not usually making these clinical situations, don't let that hold you up. Just give us your biggest opinion on when this man should have his next PSA test. We'd just be really interested to hear from you.
Yeah, and we're not going to name and shame you either. We can't see individual answers. We just get the overview. So please do dive in. Amy, you need to vote as well, please.
I will do. I have done.
Thank you. So we'll just give it a couple more seconds for people to vote. I'll see votes are coming in. We've got a nice broad selection as well, which is great.
You say you're not going to pick on anyone, and then you pick on me, and
there's still votes coming in. I wonder if people have just found the vote casting part.
Anyone who hasn't found it, where you see the Q&A option, there's a section next to it that says polls, and the question for you is in the polls section.
Okay, I think they've slowed down there, Sam. So should we
Maybe
talk through the
we go back to the case, so just we can sort of talk through the features.
Yeah, sure.
So but just in case you can't see the poll, so we've got 44% say carry on doing it 6 monthly, 31% say annually, 15% every 2 to 3 years, 6% said stop altogether, and 4% said 5 years. Right. So yeah, I guess there's a few things to highlight here. So one is the frequency of how often this person is having their PSA testing done, which is 6 monthly. which is probably more frequent than most guidelines and most trials of PSA testing have done. There's certainly trials, so the PLCO trial, the big one that was done in North America, was annual PSA testing. I'm not aware of any specific guidance around 6-monthly testing, but maybe for really high-risk men, some men might have been advised that. Obviously, this person's got a family history, so they are concerned about, although the fact that it says the uncle with prostate cancer in their 70s is having it observed suggests that it's a lower grade cancer, and the patient has some symptoms that haven't changed for a long time. The other thing this case highlights is the first PSA. So this person had their first PSA done at age 50, and it was 0.7. And something that hasn't got into clinical practice, but is certainly becoming a more consistent finding in the literature, is around the first PSA test and how that predicts a man's future risk of prostate cancer. And there's growing evidence to show that an initial PSA of less than 1 suggests that a person is at low risk, not no risk, it still happens, but low risk of developing prostate cancer ultimately. And that there are some advocates for saying, if PSA is very low to start with, then it shouldn't be done that often, or if at all. And even the European guidance I pointed to earlier, if the first PSA is less than 1, then they recommend for a man in their 50s, the next test happens 5 years later, with some caveats around, no strong family history or black ethnicity, things like that. But yeah, so it's interesting and interesting that people sort of feel to stick with the status quo. Ollie, did you have any reflections on that?
No, I think you touched on everything, Sam. It was around the point that there is a school of thought to suggest that if you do a test at 50 and the PSA is low, whether you need to check the PSA again. And I know there is some concern about non-PSA secreting cancers and the risk of men having prostate cancer with a low or normal PSA. But I think, correct me if I'm wrong, Sam, most of the cancers picked up in that setting are typically low risk, aren't they? And truly non-PSA secreting cancers, the aggressive type, are thankfully quite rare.
Yeah, no, so, and something that is relatively consistent with PSA and MRI is that the people who don't have the abnormal results on these tests, they tend to have the lower grade tumors. Not everyone, there are exceptions, but for both PSA and MRI, where there is no abnormality found, the chances of having something really aggressive is relatively low.
Yeah, and the other thing to touch on in this case is the PSA kinetics, so the direction of travel over time. So over 13 years, the PSA has doubled, which is very slow, really. You'd have expected his prostate to have enlarged during that time, as we see with age, but thankfully his PSA hasn't risen particularly high. So Sam, would you suggest, as a GP, perhaps every 2 to 3 years for this gentleman? Would you ever push to 5 years, assuming he's otherwise fitting well at 63? It's not old, is it?
No, yeah. I mean, he still has a family history. Whilst his PSA kinetics are pretty slow, as you say, and he's had a lot of tests over time. I think he's still got that family history there. Still clearly a concern there. I think 6 monthly at someone in their mid-60s might be, both inconvenient for the patient, but also a lot of tests to be done for, the health service. So, maybe pushing that kind of frequency out, and then sort of having that ongoing conversation, because, as you sort of say, having that data is really useful, because if there's a sudden change in the PSA, that might raise a red flag that something has changed. Just because prostate cancer is not present now doesn't mean it's not going to develop years ahead. But I think, keeping the conversation going and sort of reflecting on, okay, we're getting on here, PSA is not really changing, maybe we need to push this out a bit.
Yeah. And there's also the stress and anxiety about having the test, isn't there, from a patient's point of view? And I think maybe as clinicians, we don't always consider that, certainly building up to the test results and things. So I think reducing that anxiety for patients can only be a good thing, really. So I'd say every 2 to 3 years seems reasonable for that. Perhaps 5 years is a little bit long. And he does have a family history, so stopping PSA testing probably isn't the right decision here. Okay, great, good discussion. Next case. So we have a 74-year-old man who has a history of poor stream, hesitancy, and nocturia. That's getting up in the night for a wee, 2 to 3 times a night for 10 years. He's currently taking ramipril, atorvastatin, and tamsulosin, and he has a smooth enlarged prostate on DRE. A renal tract ultrasound, so an ultrasound of his kidneys, performed for a reduced EGFR, so that's his kidney function, commented upon some cortical atrophy, so that's thinning of the kidneys. And the sonographer who performed the ultrasound said that the base of the bladder was indented by an enlarged prostate with a large median lobe, and that's when we see the kind of prostate extending into the bladder, kind of forming that kind of ball valve effect, often contributing to the patient's urinary symptoms. And the sonographer's been very thorough, and they've said that the prostate volume was in excess of 120 milliliters, so that is quite a large prostate. And his PSA performed 6 months ago was 7.4. So what should the GP do next? And let's move on to the options. So again, in the poll section, you guys can vote. Response number 1 is repeat blood tests, including PSA and renal function as well. Refer on the fast track suspected prostate cancer pathway. A routine referral to the urology team for management of the lower urinary tract symptoms, that's LUTS. Discuss changing his medication to improve his symptoms. So we've seen some votes coming in. I think we got to just over 50 votes last time. So let's see if we get close to that again. So again, a nice mixture of responses, which is good for discussion.
So we're up to 35. We've got a couple of front runners here. Over half saying refer routinely to urology to manage the symptoms. 40% saying refer on the suspected cancer pathway. Very few talking about doing more blood tests or talking about his medication. In fact, no one's gone for medication at this point.
I think there was one, and they might have changed their mind, perhaps. Yeah, and we're just over 50 now. So let's have a look back at the case précis again. And which do you think from these options is the best one, Sam?
Well, I guess sort of looking at the case, and I'm going to apologize to attendees. The scaffolders outside my house taking down some scaffolding next door. So apologies if you hear that in the background. So obviously this man's got, significant symptoms that he's been suffering with for a long time. One of his medications, the one called tamsulosin, is commonly used in primary care to treat men with enlarged prostates and symptoms that are affecting their life. So, he's been tried on something. He's been examined, he's gone for an ultrasound, and as Ollie said, the very thorough sonographers assessed him. And he's had a recent-ish PSA test, which is 7.4. And for context, again, for those who are not clinicians, so the NICE guidance that has been referred to, which guides what GPs do for symptomatic men, the threshold for a man in his 70s for PSA is 6.5 or above. So technically, according to NICE guidance, he does have an elevated PSA. So maybe that's driving the people who've said, oh, he needs to be referred on the urgent suspected cancer pathway. I think, Ollie talked a bit before about, how much PSA prostate puts out and the concept of PSA density. So, simplistically, if you've got a small prostate in terms of low volume, but a high PSA level, that's more concerning than the other way around. In this case, this man has a very large prostate, and actually PSA of 7.4 might actually, I can't do a calculation of PSA density off the top of my head. I don't know if you could estimate it, Ollie, but it'd probably be pretty low.
Yeah, I just did actually. It's 0.06, and as I said in my talk, the PSA density is a bit contentious, but typically we use thresholds of 0.12 or 0.15. But that's in the context of usually a normal MRI and a raised PSA, and that's to drive what we do, a non-targeted or a systematic biopsy. But yeah, you're totally right here, Sam, that actually his PSA density is very low because he's got a very large gland, and although his PSA is raised, in context of a gland which is over 100 mils, his actual PSA density is very low. That said, he does have symptoms, doesn't he? He does have a raised PSA, and although the DRE showed that he had a smooth enlarged gland, as I touched on in my talk, the sensitivity for DRE for prostate cancer is actually almost as good as tossing a coin. So we cannot exclude cancer in a man like this, can we, Sam?
No, absolutely. There's some features like the fact that symptoms have been there a long time, and we talk about the relative volume of the prostate to the PSA to sort of say, well, is it here or is it not? I guess the thing we haven't presented in this case is the previous PSAs.
So that's true. That's true. Yeah.
Has almost certainly had a PSA test in the past. We haven't told you what it is. It might have been 7, it might have been 1, and that might change how the clinicians approach the case.
Yeah, definitely. And if we were to repeat the PSA at this point, 6 months later, and the PSA was 11, then that would probably be more concerning, wouldn't it? And probably warrant referral. And also, we've touched on the issues in primary care, but obviously, we're under pressure in secondary care as well. A lot of centres don't have a formal pathway to refer men with benign symptoms, and the only pathway into the prostate service is via the prostate cancer pathway, rightly or wrongly. And then, once these patients have either had an MRI scan, possibly a biopsy, we then look to manage their BPH and their symptoms in the non-cancer setting. So that's an issue within secondary care too, really. But which option would you opt for, Sam, for this?
So full disclosure, I said do the test again. Not knowing the previous one and it being 6 months ago, as you said, if it's changed significantly, that raises your concern. If it's steady, that maybe is potentially less of a concern. That was my option.
Yeah, no, I think that's reasonable, isn't it? I think referral onto the suspected prostate cancer pathway is also entirely reasonable. As I said, we can't exclude cancer. And I think at least an MRI scan to prove that there's nothing suspicious would be a reasonable thing to do. Hopefully, we could avoid biopsy in this situation, given the low PSA density. And if you're lucky enough to have a benign prostate clinic to be able to refer into, often these men will have a repeat PSA as part of that, even before they go for TURP and things as well. So even if you're referring down the benign pathway, it doesn't mean that the patient's going to be lost to follow up and things. But clearly the fast track pathway, things tend to happen that bit quicker.
Ollie, does the size of the prostate affect how easy or hard it is to report on MRI? I honestly don't know.
Not specifically, no. We do see with very large prostates such as this that actually the peripheral zone, where we see around 75% of cancers, becomes quite compressed. And we don't often see very aggressive cancers in very, very large glands such as this, to be honest. And I assume that's because of the dominance of the transitional zone, the bit that enlarges with age, as opposed to the kind of atrophied smaller peripheral zone. So in this kind of context, you wouldn't typically expect to see anything on the MRI scan.
Okay.
Yeah. Great. I think I can't see that there's any questions in the question bit, so we'll move on to the next case. So case number 3, we have a 49-year-old black gentleman this time, who's come to see his GP to discuss a new rash over his torso and some vague viral symptoms. He hasn't been to the GP or to the practice since moving to the area over 10 years ago. And when he's asked about his family history, he tells you that he's been supporting his older brother's family recently, as his older brother's unfortunately been diagnosed with prostate cancer at 58. And the GP offers to examine his prostate whilst he's in clinic for entirely unrelated rash and viral symptoms. But the patient refuses, saying he will never let anyone do that to him. So what should we do next? And these are the options. So do we do nothing? The patient has refused a DRE, so there's nothing more we can offer him. Do we recommend that he has a PSA test without the DRE, with no urinary symptoms, and presenting for something entirely unrelated? Do we refer him on the fast track prostate cancer pathway regardless, because his PSA is irrelevant? Or do we offer him information on prostate cancer and his risk of prostate cancer, and offer him a follow-up appointment with a GP again to discuss his risk? So two clear front runners in the responses here, Sam. So
Yeah,
we've still got some responses coming in, so we'll give it a few more seconds, I think.
yeah. It's like watching a 2-horse race. Which one's going to get first? Well, so with 40 votes, got just over half saying offering or recommending a PSA test. Closely behind in second is offer him some information first and offer him a follow-up to discuss his risk. And very few people have said do nothing or refer. Yeah, so thank you all for your thoughts. That's really, really, really useful. So again, I guess with this one, we wanted to highlight a few things. And as has been mentioned in the talks earlier, obviously we need to be thinking about the fact that Black men are higher risk and that they do develop prostate cancer at a younger age. So even though he's 49 and doesn't technically fall into the current PCRMP guidance, we would suggest that we need to be thinking about that, and he's got a family history too, so that pushes his risk up even higher. I think in terms of the DRE conversation, we sort of structured this case to sort of throw it in as a bit of a random thing, and obviously, discussing that topic because we know it's a sensitive issue for men to think about and to be concerned about, that doing it in a sensitive way, in an appropriate way, not just sort of throwing it in there as a bit of a random thing might change how men that offer's received and what men think about it. We do know not only is it sort of a general thing that men don't like the concept of a DRE, but some men refuse for cultural reasons. Some men refuse because of poor previous experiences. So there's a number of reasons why the concept or being offered a DRE might significantly put men off. So I think the majority going for offering a PSA seems like a reasonable thing to do because of he's a high risk man. Maybe in this context where offering a DRE has said, well, I'm definitely never going to do that, no thank you, maybe take a bit more of a softly approach to sort of give him some information, some time to think about it, and come back and talk about the PSA test, where, as you say, Ollie, he's come for another reason. So offering a bit of time and space to think about prostate cancer risk before going ahead with testing might be another appropriate way to manage the situation. Yeah, definitely. So I think what we wanted to tease out in this case was, the fact that as a Black man, he's at increased risk. So 1 in 4 Black men will be diagnosed with prostate cancer. But he has a positive family history as well. His brother is certainly not old at 58 to be diagnosed with prostate cancer. So his risk, again, his individual risk is increased. And it's that concept of kind of not opportunistic testing, but opportunistic discussion around his risk. And is he aware the fact that, because his brother's been diagnosed, he is at increased risk. And as a Black man, he's at increased risk as well, really. And I think I can totally see why people would recommend that he has a PSA test, because he may not come to the GP again for 10 years. And if we send him away with a leaflet or, access to the prostate risk checker, he may not be coming back to have that discussion again.
he's supporting his brother's family, presumably, he's working, and if you're not having any symptoms, it's very easy to put these things to the back of your mind, isn't it? So this might be the only opportunity that the GP and the primary care team have to, to kind of capitalize on that, really. And hopefully, the PSA will come back normal or low, and they can have a discussion about, when to repeat that. But we don't want to miss cancers in men such as this. And yeah, I think as we said previously, a DRE doesn't exclude a man from any part of the pathway. It's entirely up to them. I think the current feeling is that actually it's not entirely necessary, especially in the advent of good quality MRI, good quality biopsy as well, and it shouldn't preclude referral on the pathway. That's really important. Any more points around that, Sam?
No, I think we've covered everything for this one. There's nothing in the
Okay, and our final case. So we have a 62-year-old man who's come to see his GP, who's concerned about prostate cancer, as two friends at the golf club have recently been diagnosed. So it's good that they're talking about it. He agrees to a DRE, and the GP thinks he has a moderately enlarged prostate and can possibly feel a small nodule in the left lobe. His PSA was checked by the practice nurse 3 months ago, and that was 2.2. And he's been on finasteride, so we assume that he has some urinary symptoms for 3 years. So what should the GP do next? And we'll open the polling. And the options are nothing. His PSA is not raised, so it was 2.2. Should we repeat his PSA? It was done 3 months prior. We should refer on the fast track pathway, or we should stop his finasteride. And the votes are coming in. Again, two early front runners. So we've got just around 40 responses, and there's a clear front runner here, and that's refer on the fast track suspected prostate cancer pathway. So let's go back to the précis for the case.
Yeah. So I guess we haven't talked a lot about the specifics around the urgent suspected cancer pathway, and actually this is another one of the areas that's created a lot of confusion amongst clinicians. So the NICE guidance, which relates to symptomatic presentation in primary care for any cancer, including prostate cancer, gives age-specific, levels of, what would be considered an abnormal PSA, whereas the PCOMP has a fixed threshold of 3, particularly for men in their 50s and 60s. And besides an elevated PSA, the only other reason for GPs to refer a man on the urgent pathway to go to Ollie and have his MRI, maybe biopsy as well, is if the prostate feels abnormal to GPs. And in this situation, where as the context suggests, the patient probably has some symptoms, and the GP thinks they can feel something that's abnormal. Now, whilst we've said a normal examination should not be reassuring because you can't feel most prostate cancers, we do also know that if GPs think the prostate feels abnormal, the risk of cancer is well above the threshold for referral, and they should be referring that person, regardless of PSA. So, in this situation, the PSA was low recently, but even in that situation where you've got a symptomatic person and you've done an examination, it doesn't feel right, those men should be referred. And as we talked about, if the examination wasn't a prostate cancer that you felt, hopefully they'll be picked up on MRI and the patient won't have an unnecessary biopsy. The other thing mentioned about optimizing the use of PSA is being aware of medication. So finasteride is a medication that acts on the prostate and it lowers your PSA and can lower it quite a lot. So this patient has a PSA of 2.2. If they are off finasteride, their PSA would almost certainly be higher and potentially above referral thresholds. So this is one of those situations where knowing the full history, knowing the things that can affect PSA should probably come into your interpretation as well.
Yeah, definitely. Thanks, Sam. So when we're calculating PSA density for MRI and patients on finasteride, we typically double the PSA value. So for this gentleman, we consider his PSA, corrected PSA, to be 4.4 as a rule of thumb. So that's important to be aware of if men are on finasteride. And as Sam said, regardless of the PSA value, on examination, the GP thinks they can feel a nodule in the left lobe. And so the likelihood of this man having prostate cancer is much higher. Occasionally, these nodules turn out to be benign. So you can get, as you can get benign prostate enlargement in the center of the gland, some of these nodules can protrude outwards as well. And that's what the GP or the urologist can feel sometimes. And we can see that on MRI scans. So it's not to say that every man with an abnormal DRE will have a biopsy, but the likelihood of this gentleman having cancer, even with his relatively low PSA, is higher, given that he's got an abnormal DRE. So he should be referred on the pathway. And I don't think he had his PSA checked. Was it 3 months prior? Yeah, I don't think we'd need to repeat that. Yeah, and I think everyone suggested he should be referred on, which is good. Great. So I think that is our final case. So I can stop sharing my screen. I'll hand back to Amy.